For those
I
of
know
you
you're
who
good
don't
there.
know, your fellow student here, Chris Snider, is in the paramedic course. And yes, he's teaching a lecture that you're getting credit for, even though he's a fellow student. But Chris is not only very talented at getting points apart, across to people, as I've seen in several other interactions that I've had with Chris. He is a member of the advisory council. He's one of your student representatives on the advisory council. And he has a very, very special perception and context on the topic for tonight from daily experience and dealing with this in his own home. So as a future paramedic, as an existing EMS provider, and a caregiver at home, Chris has a unique perspective that he can share with you that will help you when you're dealing with special healthcare need patients in the home environment. I know from personal experience, many times in the almost 30 years that I wrote a box, which I haven't written a box in a few years now because my degenerative spine disease will no longer support it from years of that. But some of the scariest calls I've ever been on were special healthcare needs patients. It's just, it's really a difficult setting to walk into, and they're all different. So, Chris, I know you have the ability, or should have the ability, to share your screen. So you probably need to do that.
Right now. Okay, let me make sure I've got the right one. Here we go. All right.
There you go. All right, I'm going to turn this over to you and mute my microphone.
All right. Well, good evening, everybody. I will introduce myself a little bit better here in a few minutes. So just, I'll give you a little bit more of a rundown of my history. But for the moment, I want to go ahead and set a stage for you. For those of you who are young and don't know who Jerry Garcia is, he was the lead singer for the Grateful Dead, a band. Deadheads were a phenomenon in our country. You ain't gonna learn what you don't wanna know. And I can testify to personal experience, this is true. Growth is all about learning to convert the discomfort into comfort, and then moving on to the next uncomfortable zone. Personal growth is not a matter of learning new information, but of unlearning old limits. These are all very true statements. Think about your muscles. Your muscles don't actually grow unless they break a little bit and you become uncomfortable. This lady in this picture, she's the first female CEO of IBM. I always learned to take on things I'd never done before. Growth and comfort do not coexist. I'm writing this presentation and giving it to you guys because I grew, and it wasn't comfortable. Part of the reason I'm giving you this presentation is to hopefully make you a little more comfortable. You may question things you've seen. This may make you very uncomfortable. It was not easy for me to go through personally. It wasn't easy for me to write either. Trying to get the right words here was tough. But if that makes you better, if it makes you question things, then it's a good thing. So we're gonna set you a scenario real quick because it's an easy evening at your station. You guys, we've got dinner on. It's about 4:30 in the afternoon. You know, dinner's just finished, the pot's on the stove.
From 01050 to confirm, Red 43, 942 Taylor, drive call call, dwelling 1652.
All right, so this address, it's an apartment complex about 4 blocks from your station, 3 blocks or so. It's a medic, an AEMT, and an EMT crew. You guys, you're thinking about it all of a sudden, and this sounds familiar, and I can't quite figure out why. You rack your brain. Did I go there? And after you've had 1 call in a shift or 10 calls in a shift, they all kind of run together a little bit. So it's very possible that you may just kind of not even think about this. Apartment 141. Be advised you are being upgraded to a code blue of a 2-month-old male who is unconscious, not breathing, and CPR is in progress. Now, everybody do me a favor. I want to know who this makes their breath hitch a little bit. If this makes you a little bit antsy, I want you to go ahead and raise your hand. Seriously. Remember how to raise your hand. There's a little button right there. Well, there's Wayne. Thank you. Chat window's fine too. I'm going to tell you what, this would make me hitch my breath. It really would. There's, Patrick. Now, for everybody, Patrick is one of my friends, longstanding. He reviewed this presentation, and he's been a paramedic for at least 20 years. I think almost 30. So for him to say this catches his breath, this is a thing. So everybody hitches their breath, and yeah, it happens. Thanks, Chris. So dispatch is going to add your engine company and your law enforcement. Engines from your same station. Your battalion chief, your medic fly car, they're going to check in. It depends on the city that you live, what area you serve, whether you actually have this. You may not. So this may be a little bit of overkill. But you get to your place and you find a bassinet surrounded by equipment with caregivers performing CPR, and they've got a bag valve mask. That's going to be my first clue that something different's going on. Then you get this from the teenager in the kitchen talking to your 911 dispatcher. As you walk in the door, you hear that. That would scare me a little bit too. You've got a pulse ox, a suction unit. You've got an oxygen concentrator. You've got a feeding pump. All this is a little different from what you're used to. And then you see that BVM is attached to a tracheostomy on a 2-month-old infant. And he looks up at you and says, so who's in charge tonight? So let's talk for a minute. Who's got pucker factor going right now? Who is just pulling the seat leather out of their butt right now? I can promise you, I would be. No question in my mind. If you have one question you want to be able to ask, you may only have time for one question. What do you want to know? What's the first thing you want to know? Because it may be the only thing you get to ask. And then
Folks, you
third,
can unmute your microphone too and pop in at any time and answer the questions.
Pop in. I'll don't worry, there'll be enough time. And how much does this, or even the thought of this, scare the living crap out of you? Before September of this year, it did me. And that's part of the reason that this presentation exists. So I'm going to go ahead and I'm going to introduce myself a little bit. My name is Chris Snider. I have been in EMS since 2002 with a break from 2011 to 2019. I served in one of the busiest systems in the country for 8 years. And it was one of the most progressive systems in the country. We were very aggressive in what we did. I learned to cut my teeth in that environment. We were very high speed. Wake County, North Carolina was one of the first places in the country that did induced hypothermia for cardiac arrest resuscitations. Wake County was one of the first places where pit crew CPR was introduced. This is a place where you were on the edge. You were finding the edge of the envelope and trying to get better. But even calls like this would still scare me. Part of the reason that I'm doing this presentation for you is because I didn't get this type of a presentation, and I wish I would have. So my goal when we finish this, if you see 10,000 calls in your career, which is a great possibility, you may see special needs 10 of them. But it's going to be those 10 that are going to chill you to the bone. So I want you to have that thought in your mind. of how to deal with the most uncomfortable things you will face. So I want to give a thank you to my peer reviewers. Patrick is here. Some of these other folks, Joseph Zalkin is a nationally known instructor and is one of my deputy directors. Most of the people on this list have been in EMS for 20 years or more. And they took the time, because they know me and they know what I've been through with my family, to review this to make sure that what you get tonight is going to benefit you. So I'd like to give them thanks. And the gentleman at the very end, Trevor Bellows, you're going to see him in just a few minutes. So just keep that in mind. So let's talk about the objectives of this presentation. The first thing is to be prepared to be able to respond to a special needs emergency. They're not like your normal calls. They have their own sets of challenges, not just for the call, but for you as a provider and dealing with it, because these are going to be some of your most critical calls that you're going to see. Learn the general characteristics of special needs patients and how to anticipate what you're seeing. I'm going to tell you this focuses on pediatrics, but your special needs patients are going to be your ALS patients as adults, your Lou Gehrig's patients. They can be on vents, trachs. They can have all kinds of special equipment. These might also be your LVAD patients, because you're going to be treating them entirely differently than some other patients you'll see. Patients who suffer from a condition called primary pulmonary hypertension belong in this category too, because they have a very specific need that has to be dealt with at all times. We're going to discover general strategies for handling your own self and your anxiety about these calls and their aftermath, because it's not just going to be what happens right then. It's also going to be what happens 20 minutes after the call, 2 hours after the call, 2 days after the call. And then we're going to determine the best steps to use to prepare for these calls before they happen, because rolling up to this is going to frighten you. But if you have the ability to do some preparation before you get there, so that you kind of know what you're walking into, you're gonna have a lot better chance of success with dealing with this stuff. Now, I've got a disclaimer. 6 points on this. Number one is the information you're gonna get. Yes, we start with our textbooks, and then you get your own calls, and you get your studies, and you get your case review, and you get your peer review with your medical director. You get your advanced clinical settings. Just remember that information comes from many different places. This tonight comes from your textbook and what I've lived through. So this is my information to give to you. The call that you just had as a scenario, it's fictionalized, but it happened. And I'll explain it here in just a few minutes. This is something that my family has actually been through. So keep that in mind when you're asking your questions. I will answer your questions. I promise I will. But just keep that in mind as you're asking. Sometimes you may have to frame something a little different because you're dealing with a very personal situation. The third point is this. When you're dealing with special needs, a lot of times parents of special needs kids, they'll publish their stories. And that's great. But what is kind of cute when you're 2, talking about how little Johnny took his first poop in the toilet, isn't so funny at 12 when he can actually read that and be very embarrassed by that. So because of this, my wife and I talked about it. We will refer to our children, we have 3, by their initials in this presentation to protect their privacy. Because as you heard Ms. Dinsmore say, this is probably going to get recorded, and as long as the quality is good, it's going into the curriculum, which means it's going to be there for a while. I want to make sure that just in case my son sees this, this isn't going to traumatize him in any way. Number 4, feel free to ask questions. There are 6,000 or 7,000 questions I still have right now that I have not been able to ask about everything that's going on. Ask your questions. You can unmute, you can use the chat window. I've got the chat set here right beside me so I can see them as they come in. I will happily answer them. When I started this journey, I had already been through neonatology, special needs, chronic healthcare challenges. I still wasn't prepared. Yes, it is. Okay, we traumatize the oldest one all the time, Wayne. But I thought one of our jobs as parents is to find new, unique ways to traumatize our kids when they become teenagers. Very true. However, there's a difference between needling and actual developing a hate relationship. So I'm trying to avoid the latter and do the former. We needled my son just the other day because he didn't understand what lube was. We have to lube my son's trach, and he didn't understand the other uses of that. So that made him very embarrassed and red-faced, and he ran to his room. Successful. Yes. This one. I'm still dealing with the hardships, the trauma of what we went through in the months of November and December. This is a way of catharsis for me. If I can do this, give the information to you, and it helps you to be a success in these types of situations, I'm going to be better because I've helped somebody else get better. So that's part of the reason that I've done this. Also because, again, this is a subject that's very much, you're not going to find a lot on it. So maybe this will help. So I hope this helps. And now, please meet my son, G. He was born on September the 25th, and yes, those are his dragons above his head. He is our own little Game of Thrones fan at the house. We weren't expecting a baby that day. My wife was not due for another 4 weeks, but they weren't going to let her go to full term anyway. But then she started having issues. My wife suffered from polyhydramnios during her second pregnancy and now during this one. And so we went to the hospital with the intention of having an amniocentesis. They drew off 3,800 cc's of fluid. To let you know, that's about what you're supposed to have. And then she still had more. But they noticed that G began to have some decelerations in heart rate. It worried the nurses to the point that they said, we're going to go ahead and start your induction. And then they kept kind of leaving the room, finding different people. And then we got to this point because they kept saying, well, we need to go find the doc. And then they said, no, we need to go ahead and call the OR. And then they said, no, we need to be walking to the OR. And they literally wheeled my wife out of the room in front of me. From that point, they took her down to the OR and they were going to do an emergent C-section, but they ended up needing to do a crash C-section. And we went from inducing to crash in 22 minutes. So I want to ask, and somebody feel free to unmute, what is the difference between a crash C-section and an emergent C-section? Yes, ma'am.
I believe a crash C-section is when you're working up the mom because they have crashed, basically.
So a crash C-section, close. A crash C-section is, instead of you being put under spinal anesthesia, like a normal birth would be, you are taken down and put under general and crash intubated. That's what a crash C-section is. They decided that they needed to do an emergency section and were going to do the spinal. She said that she was sitting forward, and then all of a sudden they said, lean back, breathe here. She said a nurse got up on the bed and started praying with her. My wife thought she was going to die. So they're in the OR. We have the C-section. G was born, and his 1 minute APGAR was 1. I believe, if I remember correctly, the only thing that got a score was his heart rate. Nothing else. His 5 minute APGAR score was 4. And his 10 minute APGAR was 4, except they intubated him in the OR and started ventilating him. Now, that's one corner of the room. The other corner of the room is my wife, who is currently still basically bleeding out. She had to have 2 units of packed red cells plus 3 liters of fluids. And they said that they could not get things to stop bleeding. They finally did. It took some labetalol and some epi and a few other things to get things where it needed to be, and she was able to be taken to recovery. In the meantime, G was taken to the NICU, where he remained for 37 days. Some of his diagnosis, among others, he has a condition called Treacher-Collins syndrome. Treacher-Collins is a collection of craniofacial abnormalities, usually classified by ear abnormalities, eye abnormalities, jaw abnormalities, and a cleft palate. Usually the ear abnormalities, a lot of it's external. So we're not sure what hearing he has, but we're pretty sure that he does because he reacts to different things that are sound-based. But it's going to take a little while to get that totally figured out. He has choanotresia bilaterally. That means that his nose does not join with the nasopharynx. There's a piece of tissue in here that's supposed to drop off, and it did not. So only one nostril halfway works. He has microtia or anotia, which is a lack of ear or small ear, the external structures specifically. He has bilateral microphthalmia, which means his eyes are smaller than normal. And he has mandibular hypoplasia. So he has a small jaw that is recessed. In some of the pictures we have of him now, because he's starting to gain weight, he has a double no chin. That's what we refer to it as. It's very cute. It's very cute. So day 12, they had originally intubated him. He was extubated, but he was not able to maintain his airway even with a CPAP. So they decided to re-intubate him, and then a tracheostomy and a G-tube was placed. And that's what he has now. Day 22, we had an MRI of the spine. They were checking for spinal foramen narrowing. It does continue to be watched. There are some other neurological issues they are checking for. Day 30, they were worried about panhypopituitarism. It has been discounted. His hormone levels are all where they need to be. They're not so worried about it. Finally, day 37, we get to discharge, except for the fact that on day 23, he had to have a surgery to repair an inguinal hernia. That nurse actually, he still sees her occasionally because she's a home health nurse, and he cannot stand her. It's kind of funny. She was the one who found his inguinal hernia and made him go under the knife. But we'll get to discharge right now. This is discharge, November the 3rd of 2020 from University Medical Center in Lubbock. This is my son in his car seat. And we actually had to use all those blankets to prop him up because he was just so small. November the 5th, we went to the pediatrician's office and we had a clean bill of health. And that's important because of what happens next. Later that night, we had an episode of respiratory distress. He took a breath in, he couldn't exhale it. And so we decided, rather than take him to the ER in our hometown, which did not know anything about him, didn't have any equipment to treat him, to take him up to the ER where his pediatrician was, because she knew about him. She had equipment ready to treat him. We called her on the cell phone, and she met us there. Within 3 minutes of our being at the ER, she was at the hospital. And she treated him. We made a decision. We were going to transfer him to Lubbock, back to where he came from, because we weren't sure what was going on, and we wanted to make sure we had every base covered. One thought, how to transfer a patient. Just so that you know, air ambulances are not cheap. When you are talking about a pediatric, they are even more expensive. It is a consideration. I know that patient condition is going to ultimately trump everything, but forcing a family into bankruptcy because they can't pay an air ambulance bill, if we're patient advocates, we need to make sure we keep an eye on that. So it started out that we were going to go by air, but he did better. He was improving. So the decision was made, let's send him by ground and we'll just have him there. So we went ahead and started making those preparations. In his car seat during the transfer, car seat strapped to the ambulance gurney, 30 minutes in, he was noted to be cyanotic and not active. He had had a displacement of his tracheostomy tube, and he was in respiratory arrest. Exactly what happened isn't important, but I want to make a note that even if you have a caregiver like me, I was with him, you are still the provider, which means you need to make sure that you are staying on top of everything. I won't say any more about it right now. I may get into that a little bit later. So pulled over, side of the road, a couple of chest compressions, and he came back. He was crying. We were able to reinsert the trach. I did it without any type of sterile technique. I just kind of aimed for the hole and hoped for the best. He was bagged. The question was, do we turn around and go back to Lovington? Do we wait for a chopper there? Do we go to the next town and get a chopper? We made the decision to go back to Lovington. They had a chopper actually standing by on hot load. And the crew got in the ambulance and goes, we can't take him. He is too small. The minimum for their ventilator was 7 kilos. So they stayed in the truck with us. They did some procedures on him. We took him back to the ER, and that flight crew stayed with him for about 2.5 hours. His pediatrician returned, stayed there all night with him until the next morning when she had to open her clinic. A NICU team came and got him. So he was flown. The NICU, the nurse who was actually on the team was one of his nurses when he was in the NICU originally, and she knew him. We had stuck him by that point 9 times to try to get a line, and no success. They didn't want to put an IO in. He's actually too small at this point to have the easy IO. The gun or the drill is great, but you got to have a minimum weight for it, and he was under that. So they flew him back. He went back to the NICU. He stayed 11 days. He had another respiratory arrest, which required chest compressions while he was there because his trach clogged with blood. There was more education. There was more training. There was a lot more reassurance to us as parents that, no, we were doing the right things. And then he was discharged home again, and we were good. Well, the night of November the 19th, he had another trach displacement and a respiratory arrest in our home. It required chest compressions. We took him to the local ER this time, and they took him back to Lubbock, and he went into pediatric intensive care. I felt, for those of you who have ever heard of Chicken Little, I felt like Chicken Little screaming, the sky is falling, the sky is falling, and nothing happening. Well, he had another respiratory arrest during his stay, and I was sleeping beside him when it happened in my chair. And the staff saw it. They're like, okay, it was idiopathic. It just happened. So I don't feel so bad now. I know that he actually has. We are discharged the day before Thanksgiving. We have had discussions with his general surgeon, with his ear, nose, and throat doctor. He has a new trach at this point. The trach that he is getting fitted for now is a cuffless trach, and I'll explain that here just shortly because I'll actually show you. But everything's great. Trach's good. Doctor's appointments go well. Clean bill of health. December the 7th, we have some friends over to the house. My friend's wife was holding G, and he coded in her arms. Fib seizure, the full thing. So if you look at this picture, the gentleman standing in the back with glasses and no mask, that is my friend Trevor. He's one of the peer reviewers for this. It was his wife who was holding G when he coded. He and I worked the code together. This is EMS in our house that night. There were 14 people in our house. We took him to the ER, and the doctor makes this statement when I walk into the room. I've never seen a trach in a baby this small. What would you like us to do? I don't care if you're a parent of something like this or not. As a provider, this would scare me. As a parent, this terrifies me, because that tells me that you can't help me. And that is a scary thing to me. Funny story, if you can call it funny. As we're going into the ER, they call for respiratory because we now have a post-code baby. And respiratory comes bebopping in the room holding a pediatric nasal cannula in his hands, just like this, for a 2-month-old. I don't know what he thought he was going to do. I didn't ask a whole lot of questions. I just kind of laughed at him and shooed him out of the room. This statement, I've never seen a trach in a baby this small. What would you like us to do? Said by a doctor, an MD with at least 10 years of experience, is why we're here today. So I'm going to stop. Anybody got any questions right now?
If you were to go, if you were to have an emergency in your house and you had something like this happen before, where you knew your local ER couldn't handle your pediatric, say it's another week down the road, and your same fire department shows up, could you request, and say you're the provider and you're showing up to a house like this, and they request a different ER because they know that this ER can't handle it? What's your decision on that if the ER is way too far?
Well, okay, so you have two, so that's you got a couple of different things here. You've got to do one of two things. Number one, if you're working an active code, under no circumstances can you bypass the local ER. It's not going to happen. But let's say you have this baby who is post-code or is not code. The question of taking the child to a more advanced facility that can care for them versus taking them to the local hospital is going to rest in your protocols, your medical director, that hospital, because they're your online medical control at that point. Wayne's right, closest appropriate facility. But appropriate is defined by the state, it's defined by your medical director, it's defined by your protocols, and it's defined by online medical control. These are situations where I would tell you, have a conversation with online medical control. I tried to get them to have a conversation with online medical control this night, and they refused to do so. I want to make that clear. I tried to get them to have a conversation with online medical control and get him to the hospital with equipment for him, and they refused to have the conversation. I've already said my piece to this department in that regard. And doing so shot myself in the foot for a job opportunity. I didn't care at that point. My kid's health comes first. Does that answer your question?
Yes, sir. Understood.
Okay. Anybody else? All right. Then we're going to move on. We're going to keep going. So I want to talk about the characteristics of special needs parents. Because, and I'm going to use the word parent, but you can also substitute caregiver. You can substitute nurse. Anybody who is going to care for a special needs patient, whether they are 8 days or 80 years old. You're going to find one or two types of caregivers. I use the word parents here. Just remember, parents can substitute. 90% of these folks, they are experts in their particular person's illness and disease process. I can tell you every bit of my son's issues and how to deal with them. They can give provider level care for what's going on. I am certified in the state of Texas and licensed in the state of New Mexico as an EMT. Tracheal suctioning is not in my scope of practice, but I know how to do it. Trach changes are not in my scope of practice, but I know how to do it. Because we have been taught to give that level of care for our son. Take account, it's provider level care, not provider level care. But the second part of this, as long as they aren't in a panic for some reason, and I'm going to tell you what, it doesn't matter, it might not be me, it might be somebody else. They are the best source of history you will ever come across. They know the last dose of meds. They know everything that's wrong with their child. They know every single bit of information that you will need and probably can hand it to you. So you'll never have to worry about having a lack of information 90% of the time. However, let's go to the other little bit. 10% of these parents, and they split into two groups. You have number one, they're panicking. Whatever is going on, they're panicking and they cannot help you. And it happens. Something that goes well beyond their level of being able to do anything. Me in the back of that ambulance, I was this 10%. Or they have chosen to what I call check out. And don't give a flip is a very relative term. They've dissociated. They just don't, at this point, they don't care. Whatever has happened, it's just numbed them, and they're not going to care. They're not going to help you. And that's sad. Unfortunately, it is a reality in these situations. And the nature of EMS, you don't get to choose which set of parents you get. We run the next call that comes on the pager or comes on the MDT, and that's who you deal with. So a brief note now. This is my son's equipment at home. I'm going to show you this. This is everything's going to look a little different no matter where you go. But ask that caregiver or parent, and they'll tell you. They'll explain to you how it works. They'll explain to you what they need to make it work. And they'll explain to you what happens when it malfunctions. The one thing that will help with these all different setups is the word pre-planning. Now, all the firefighters on here, you know about pre-plans. Law enforcement officers know about pre-plans. We do them. There's no sense why EMS can't take a pre-plan, because we pre-plan large events. We pre-plan the rock concert that's going to happen down at the amphitheater. We pre-plan the school for the active shooter. Why can't we pre-plan our special needs patient who we know is going to need more time, more of our skill level? There is no reason that we should not be able to pre-plan this and get some help. The fire department, they've already had training on his specific issues and some training with his equipment. They do EMS around here. I continue to interface with them. On the front wall of my house, right beside his schedule, I have a spreadsheet, and I have it on my computer. It is their drug concentrations. I went to the station, and I specifically took a look at what their concentrations of medications are, and I have his weight. And every time he goes to a doctor's appointment, I plug his weight into that spreadsheet, and it reconfigures every drug dosage that he would need, not only just the milligrams, but also how many milliliters to give my son. Because in the situation where he needs it, there's not going to be a lot of free thought that's going to be available. It needs to be focused. They have appreciated this, and I'm glad they do. Starting that spreadsheet took a while. I was having a lot of trouble with formulas, and I'm pretty decent at med math. The ER where his pediatrician is, they have training on what would happen if he comes in. There's literally a box on a shelf with his name on it. And all they have to do is, if they know he's coming, they'll pull the box down, put it beside him, put it in the room. It's got a trach, it's got a G-tube, it's got everything there. And it's really nice. And there is a specific respiratory therapist. They will call from home to come and sit with him. The ER where the staff actually wants to meet with him, kind of use him as a crash test dummy. The ER in our local little town now. I had a meeting with their CEO, and they think this idea is great because, again, I'm in a town of 47,000 people. How many times do you see somebody like him? It's not often. So having this type of interactive training is a good thing. So I want to show you something, and do me a favor. Everybody unmute for a minute. Every single person. Okay. and I'm doing this for a reason. Every single person on mute. I'm getting ready to show you a piece of equipment. This is my son's trach in my hand. Now, who is a little freaked out by that?
I certainly wouldn't want to place one.
It's a little tough, I will admit. And even for me, having done it 15 times, it's tough. For those of you who need to know, this little metal rod right here, it's called an obturator. Think of it as a stylet. Everybody can go ahead and mute back now, unless you got a question. It's a stylet. Unless it's the most emergent of circumstances, that obturator is inside that trach when it's inserted. No questions asked. Now, when I said in the back of the ambulance that I inserted his trach without the obturator in, I just kind of aimed for the hole and hoped for the best. It's because I didn't have one with me. For some reason, the obturator got left at the hospital and it got taken home by my wife. We didn't think we were going to need it. No more. There's one with us at all times. So let's take a look at some pictures real quick. So this is a busy slide, and I apologize for that, but in no particular order. You've got an oxygen concentrator. It's on the bottom of that cart. You've got a precision flow meter. It's the little triangular box. The concentrator gives you from basically 1 liter to 5 liters, and it doesn't really allow you to dial the oxygen flow very well. My son is on 0.1 to 0.3 liters per minute. That precision flow meter allows us to dial very specific numbers in so that we don't over-oxygenate him and we don't under-oxygenate him. You've got the pulse oximetry. That's a Massimo pulse ox right there. And I will say that the Nellcore probes that go with it are absolutely atrocious, but we don't have any other choice because that's what we have. So we have made do. We found ways to make them work a little better. There's a feeding pump you'll see in a second. Right down at the lower left corner below the arm of that couch is a suction unit with rigid and soft catheters, because we suction the trach with a soft catheter that's sheathed, and we suction the other upper airway, the mouth, and the nose with a rigid catheter. We have spare oxygen tanks in our house right now. There are 6 with a special flow meter on it because, again, he's on a very low flow of oxygen. There are many medical supplies. We've got sterile water. We've got catheters. We've got cotton swabs. We've got cotton balls. We've got HMEs, which I'll explain what an HME is in a minute. You've got all kinds of stuff. There's sterile gloves. Sterile gloves were a pain to find. I will say that. And then now, if you look up, you see the feeding pump on the pole, and in the bag hanging beside him is a bag valve mask. The bag valve mask, believe it or not, was the hardest piece of equipment to get. When he first came home, they gave us an adult bag valve mask. We told him it wasn't appropriate, and then they gave us a pediatric bag valve mask. Getting an infant bag valve mask from the durable medical equipment company took almost an act of God. For one reason. Does anybody want to guess what it is?
Availability.
No, not availability. Wayne's got it right. Cost. So an adult bag valve mask is about 19 bucks. A pediatric bag valve mask is about 22. An infant is 50. They didn't want to pay for it, believe it or not. So that was the worst piece of equipment. That's the piece of equipment that took us the longest to get. And then right above him is Captain Calamari, because everybody needs to have a little something that they can play with, and that's his. Captain Calamari is what he plays with, and he enjoys it, and he reaches up and grabs it, and it's all good. Now, we also have emergency equipment. This red bag is referred to as the oh shit bag, because generally that's the word we're using when we grab it. In that bag, we have A spare tracheostomy in the box. That's the thing with the orange label on it. And it's got the obturator. It's like in the packaging, it's still sterile. A bag valve mask. We managed to have a second one that kind of mysteriously found its way into one of our discharge bags, and we don't know where it came from. Hint, hint, wink, wink. Supplies for a trach change, full supplies. Spare instruments. We carry Kelly forceps, we carry curved Kellys, we carry Lister bandage scissors, we carry a full set of instruments so that we can do anything we need to do while we're there. We have oxygen tanks. We always carry 2 with us, one with the regulator on it and one that's sealed so that we have it if we need it. The suction unit with both the sheath and the sterile catheters. One other thing that we have in that bag is a G-tube, a new in the box G-tube. And then I'd like to introduce you to Teller. He's one of our cats. He is a giant attention hog. That's a nice way of saying he's a little whore. And he tries to jump into my son's bassinet any chance he gets. I don't know what my son thinks of this. He hasn't been able to tell us, and he doesn't really swat him away or anything, but we don't really want the cat in the bassinet with the baby. So we have to consistently try to get Teller out of there. Now, before we continue, everything so far has been geared towards my son, towards learning his journey and how it made me come to this point. From here on out, we're going to talk about strategies and being proactive in these types of situations. One specific child versus how you can take what we've learned and put it to use in your own practice. So does anybody have any questions specific to my son or our family? This is going to be your moment to ask them. And Wayne, I see what you sent me. I'll get with you.
And not a question per se, but just looking at your pictures, I will say one thing we found on a call we ran, not even on a special needs case, but for your soft suction catheters, like you're going to use for a trach tube, we had 2 different ones from Dynarex and I believe Cureplex.
I think I know where you're going with this.
And
they're labeled the same number and they're different sizes.
We switched from Yonkers to Decanto catheters, and the Dynarex soft catheters fit the same suction tubing as our Decantos. The Cureplex did not fit. We learned that the hard way on a call and had to jury rig a seal to get suction.
So with ours, it wasn't that they didn't fit the suction tubing. It's that an 8 French in a sterile packaging and an 8 French with the sheath are actually 2 different sizes. We didn't know that. We found that out. And so if you go up to a 10 French, the 10 French, one of them won't fit in his tracheostomy. It's just kind of weird. And I brought that to the attention of our durable medical company because they need to know that. They need to know that, well, when you step up a size, we're going to have problems. They are aware now, so they can start dealing with it. But yeah, different companies have different sizing of medical equipment. I don't understand how it happens because my brain, a milliliter is a milliliter, French is a French, it should be the same. It's not. You're going to have to, that's part of the whole pre-planning thing. You got to find out what these parents have because they may have equipment that doesn't interface with your equipment. Case in point, his flow meter for his oxygen tank. It's very specific. His flow meter for his portable oxygen tank only goes up to 3 liters per minute, and it's very finely graduated. What's the standard O2 regulator go at? 0 to 25, right? 0 to 25 liters per minute, and your first graduation is at 0.5 liters per minute, and then you go to 1, and then you go to 2. So keep that in mind. Peyton, you were getting ready to chime in with something.
Yeah, my only question was, so I know like a lot of the stuff in your picture was pretty straightforward for providers and walking in there, but what would be your biggest thing or biggest concern or I guess pucker factor when you walk in, you look at all this equipment? What's the biggest thing that's going to draw your attention?
With me, honestly, if I was given the scenario that I had at the beginning, it would be, it's not the feeding tube, It's not the oxygen. It's seeing that bag valve mask on that tracheostomy.
Okay.
Because you've got an infant with a trach.
Yeah.
I've seen patients with feeding tubes from 4 months to 44 to over 100 years old. But an infant with a trach knew when I got Griffin or when I got G. So completely new to me. That would be the thing that freaked me out. And that's what the paramedic actually told me, who was on the first call the first time they came to the house, was the trach was the thing that freaked him out.
Makes sense.
Okay. Anybody else?
Yeah, Chris,
Yeah,
if
I
I
got
could just ask you one question here. Under your pre-planning, I see that you went with the EMS and the fire department. Did you also meet with the dispatchers at 911 so they have a data sheet for your address,
No.
etc.?
I did not. The fire department went ahead and put that in themselves. And I'll come to that here in just a few minutes. You jumped ahead, but it's okay. Somebody else popped in. Who was it?
Yeah, I had really
Yeah,
quick.
Will.
It's maybe kind of a stupid question, but
No, there are no stupid
like-
questions.
removing equipment that is kind of in the home, like how do you go about that? Whether it's like the oxygen or anything else, like how do you recommend? Like, do you transport that with the patient or?
Well, okay, so it depends. I'll take the feeding pump for an example. The feeding pump, he has specific feeding bags and stuff that are him, but the hospital will have some type of equipment. The question is whether it's going to be compatible or not. A little bit further on, when I'm talking about strategies, I'm going to talk about the fact that you should always make sure to tell these parents, take equipment with you, because you never know if hospital A is going to have a different place than hospital B, and it's going to have a different way of doing things. So you have to be proactive in that approach. And we're going to get there in just a few minutes, because we have a box and a bag that goes with him. The red bag, again, the oh shit bag, that is immediate needs. But he also has a backpack that his feeding tube goes in, and we have the ability to put extra bags and extra formula in there. And so we take the pump, we put everything in there, and that may not go in the ambulance with him, but it may go with my wife following the ambulance. Make sense?
Yeah, a bit more. Thank you.
Not a problem. Anybody else have anything they'd like to ask? Please do. Seeing none, hearing none, let's go ahead and go. So what can you do? The first thing, yes, this slide does look the same. Let's talk about pre-planning. No sense that EMS can't do a pre-plan. The first thing, take time, plan what you need and who does what. Just remember, an EMT is not going to be able to do the same scope of practice that a paramedic is. Plan for that eventuality, especially if you know you've got somebody like this in your community. Interface with your medical director and their primary care physician, or better yet, have those two doctors interface with each other and then report back to you. It's a part of the process. It's not going to get an expanded scope of practice. It's more just a dialogue. In our case, we had our pediatrician interface with the local medical director. One of the reasons was we wanted the ability to transport him past the local hospital to the hospital where his pediatrician is. They didn't have equipment here to do it. The medical director wouldn't do it, but at least he now is aware that my son is a special needs patient in his community. You're going to have different responses. Depends on how much your medical director is willing to push the envelope a little bit. You just have to take it by ear. If your medical director doesn't let you transport to a hospital that's going to take care of him, this patient, then it becomes incumbent upon you to be more proactive in getting your local facility set for what they're about to get. Do you need extra training on this patient? Is there equipment that you're going to need to learn? Is there procedures you're going to need to do? Do it first. Don't wait. The first time you want to learn how to suction a trach is not when you're standing there with the patient in a critical situation learning how to do it. That's not when you want to do this. You want to do it first. Involve law enforcement. Involve other agencies because you might need them, traffic issues, etc. To Patrick's point about interfacing with 911 to have this house set up as a special needs. We do have our house in CAD as a special circumstances house. The problem is you can't differentiate usually between one person at the house and the rest of the house. So no matter who calls 911 for an EMS need, we're going to get an ambulance, an engine company, the battalion chief, and law enforcement, even if it's for my daughter having a stubbed toe. It's one of the, sometimes CAD's a little narrow. It's one of the drawbacks. But yes, have that conversation. Some of the newer CAD systems may be able to differentiate between people in a household. And if it's the 2-month-old, a flag goes up and all of a sudden you get equipment. And if it's the 40-year-old, no flag and you don't need anything. What about traffic? Remember I talked about primary pulmonary hypertension. Those patients, they have an infusion that's going, and if they lose that infusion, they have 20 minutes to get it restarted or they're going to be in a world of trouble. You may need law enforcement to block traffic for you to get them to that facility where they can be taken care of. Because if after that 20 minutes goes, all bets are off on what's going to happen. That's a special need, and that's something that you have to consider. Determine what situations can be treated at your local place and what situations need to go further. Always remember, active cardiac arrest goes to the closest facility, no questions. Active respiratory arrest goes to the closest facility, no questions. Beyond that, you may have some flexibility built into your protocols to be able to transport a patient to where they need to go, not where they go locally. You have to that's again, that medical director interface. Talk to your medical director, find out what they're at. Here, we have one hospital in our town. We have a hospital 20 minutes north. The nearest major facility for special needs is going to be 104 miles northeast in Lubbock. You just have to, go to the local hospital here. Sometimes you may be able to go somewhere else. Any hazards in the home or getting to the home, which could cause issues for you as the crew or your patient. Dogs, cats, again, Teller wants to love on everybody when they come in the door. What about the fact that you might have to cross, a bridge to get up to this house on the hill where there's a patient? That's a hazard. And it's going to prevent you from getting in and may prevent you from getting out. Is there an angry neighbor that every time you go, he's mad because you block the street with all these vehicles? That's a hazard. That's a hazard that you may have to deal with even more. Determine these hazards, make a plan for them. And make sure that whoever's taking care of these patients know the limits of your scope of practice, because my son's nurses can do things that paramedics in this state cannot. And we need to make sure that they know what you can do, but also what you can't do, and they will have to. If there's a specific medication that has to be given that only they can give and you can't, definitely do not want to get outside your scope of practice on this. You want to make sure that you're within. Places like Texas where there's delegated practice, you may be able to have things added to it, but most states aren't like that. So keep that in mind as you're doing these types of things. So let's talk. What about before the call? Number one, knowing this person is there is the key to any success you're going to have. Ask to talk to the parents. More than likely, they are more than happy to talk to you because they know that they're going to interface with you if something happens. If they're willing to have the discussion, the entire first time you have to go over there on an emergency goes a lot smoother. I wish the fire department would have done so. Here, they didn't want to. I didn't want to. I still don't have a lot of confidence in our fire department, but I'm a little bit better than I was before after having these discussions with them on his care. The first time we called 911 was actually because his oxygen tubing became displaced. It wasn't because he was in an arrest. It was just because we couldn't get his oxygen tubing back, and it was a simple thing. I was not at home that day. Have them reach out to the local ER if that's not where he came from. If you're not in a big city and this is a patient of special needs coming from the big city to your local, get those parents in touch with that ER. Have that interface started So that way, the first time something happens and you have to take that patient to the ER, they're prepared. It will go a lot smoother. That doc in the ER, that statement is very scary. It really is. I've never seen a kid this small with a trach. I live in a small community. I can believe that. Doesn't make me feel any better. Number 2, train, train, train. The whole rule of train as if your life depends on it, because one day it will. Folks with special needs are not calling you because he's sick. I'm trained. If my son is sick, we put him in a car seat, we take him to the doctor. We call the doctor on the phone. We don't take him to the ER. We don't pack up and go. If he's having a problem with his G-tube, we take him to the physician in Lubbock. We don't call 911 for those types of things. Whatever is going on has exceeded the scope of what we would normally be dealing with. It is an emergent situation. They need immediate assistance. They're not calling for sickness. They're calling for critical. You got to understand that mindset on this. We won't call 911 because of a sickness issue. We'll call 911 because of a critical issue. We deal with sickness in the way we've been taught to deal with it, which is to go to the local physician, to go to our physician. And then there's the adage, don't train until you get it right. Train until you can't get it wrong. It really is the truth. Third thing, it's okay to have this bit of anxiousness. If you present yourself in that situation at first with the cardiac arrest in a trached infant and you're not anxious, you're not human. You got to know that your anxiety is allowed. How many people know this quote? Courage is not the absence of fear, but the assessment that something else is more important than it. Does anyone know who said that? Go ahead and unmute and just say it. Anybody? I'll put it this way. I'll give you a hint. Comes from the same speech as the only thing we have to fear is fear itself. Anybody? Oh, come on, Franklin Roosevelt? I'm a little sad. Man, I like history. An air of confidence is important. It's not a know-it-all statement. You don't know it all, but you can help. That's the important part here. You can help. And it's not shameful to call for help. Getting hands available is a good thing, especially because you don't know how many you may need. Everybody still with me? David? Okay. I'm just making sure. Jonathan, you still there?
Still here.
Okay. So now you're in your critical situation. Take a deep breath. No, seriously, take a deep breath. It's going to be okay. You get dispatched to the house where you've got the trached infant on the vent. Take a deep breath. It will be okay. If you're not calm, you can't do anything to help people. Get help. Call for help early. Call for help often. There's no shame in calling for people to help you in these situations. Your extra hands will not be unappreciated. It may be tough to find a place to put them all in a small house, but you can use them. Keep your equipment light and tailored, because you don't need to bring in every piece of equipment in your truck. You need to have what you need to have for that patient, knowing they're probably going to have equipment in the house for you, knowing that you need to be prepared for what's going on. They may have an equipment failure is the reason you're going. Remember that you can bring in a PEDS bag. You can bring in an oxygen bag. You can bring in a cardiac monitor, and you can bring in a clipboard to take some information. And also remember one other thing. These parents are going to be a resource. They're also going to be an extra set of hands for you. Remember, they're trained at this provider type of a level. So they can be a set of hands if you need to send somebody out to the truck to get something for you. Utilize those parents, because that's one thing that may help them. If they're having a little bit of a drift towards a panic, if you give them some guidance to get them to help you, you have reassisted them in getting back where they need to be able to help you. But remember, like I said before, you are the provider. You have to be the provider in this situation. Yes, the parents are a resource. Yes, they can help, but you are the person who's going to have to be in charge of that call. Remember to continuously reassess, because these kids, it can change in a heartbeat. These adults too, if depending on what they have. LVAD patients can literally change in a heartbeat because they don't have one. You need to focus on the moment. If you can focus on what am I going to do in the next 10 seconds or the next 20 seconds, you have done better. Famous person in the pre-hospital world is Norman McSwain. He's a doctor. He wrote a set of rules, and one of his rules is every minute has 60 seconds. Do not waste them. If you're able to focus on the moment, you can help yourself and you can help everybody else. Third thing, back to what Wayne is saying, back to what Jonathan and Peyton are saying. Will, advocate for your patient. Sorry, I hit the wheel. I apologize. If your local hospital can't help, get them someplace different. If you can't get them there, use other resources to get help to this patient. And don't worry about the next call. We see one patient at a time. We are a very unique practice in the scope of medicine. We see one patient at a time, and then we move on. You don't have to juggle 6 patients unless you go to a multi-vehicle car wreck usually. You focus on one patient at a time. There are other trucks that will get the other patients. Use your patient minute for your patient. Help the parents out. They may be a little bit overwhelmed, and that's seriously true. This is the one where I get to do the we goofed. That last night we took our son to the ER. We grabbed the red bag, we grabbed his diaper bag, we grabbed the feeding pump. We forgot one important piece of equipment. Does anybody want to guess what it is? Patrick already knows. He's already heard about this. Come on, somebody chime in. I feel like I'm talking to myself. What's one important piece of equipment that you cannot forget when you're dealing with a pediatric?
Some sort of toy, stuffed animal?
No, that's important, but not as important. There's one very vital piece of equipment.
Wayne said O2.
No, it's not the O2. The car seat. Don't forget the car seat. Transporting your patient in the parent's arms is not an advisable thing, sometimes necessary, but they've got to go home from the hospital and they've got to go home in their vehicle. And if that patient's stabilized, they're not riding in mom and dad's arms, they're riding in the car seat. Don't forget the car seat. Yep. Just make sure you unmute if you want to say something. I promise I'll listen. So now I want to talk to you about breathing, and I seriously want to talk to you about breathing. These calls are panic inducing, but it's going to be okay. Everybody panics. I panic. I still panic if an alarm goes off and I can't figure out why it's going off. Everybody gets a racing heart. But EMS is predicated on bringing a little bit of order to a lot of chaos. You've got the training now. You can be the voice of calm, the voice of reason, the voice of order. And it doesn't have to be just to that patient's family or to the bystanders. It can be to your crew who doesn't quite know what's going on and never thought they'd see this. 2005, my first pediatric code wasn't a code, it was a status seizure, and I was freaking out. And I had a paramedic who calmed me down. He was the voice of calm in that instance. You now can be the voice of calm. Now, I had to add one more slide to this today. I had this thing all done, and something happened yesterday. After the call, document accurately. The old adage, if you did it, write it down. If you didn't do it, if you didn't write it down, it wasn't done. But here's another thing. If somebody who was not you on your call had to do something, if I have to suction my son's trach, it has to be documented if it was done in the back of an ambulance. Document it properly. You didn't do it, the caregiver did it. And it has to say the caregiver did it. You may not be able to put it on your PCR in the procedures or the action section, then list it in the narrative. Patrick and I had a medical director. His name is Dr. Brent Myers. He is the former president of the National Association of EMS Physicians, and he has something he calls the sins of omission and the sins of commission. The sins of omission is not doing something or not writing something down. The sins of commission is doing something wrong. Okay? I went yesterday because I'm having to fight for an air ambulance bill. And I got this handy dandy run report from the EMS agency during that failed transfer. And I started reading it. And as I read it, I realized that that paramedic did not document 4 vital actions. Number 1, she didn't document the displacement of the tracheostomy. Number 2, she documented that she performed bag valve mask ventilations on him all the way back to Lovington. She didn't, I did. She did not document that a flight crew got into the ambulance and did a sterile trach change in the ambulance. She didn't do it, but it was done in her truck. And then she also did not document that she did not have good eyes on the patient at the time of the arrest. So now I've got some decisions I've got to make in regards to that. Document correctly. And then this would be considered a big problem in most EMS systems. If something happens during a call like this, like the transfer fails because your patient goes into respiratory arrest and you have to return to your facility, maybe you ought to tell your medical director about it. Do you really want them finding out later? Somebody tell me what happened the last time your medical director found out about something after the fact that they didn't know that they should have. This is a time for you to open up your mic. Come on. What happens if your medical director finds out about something that you weren't expecting to happen?
Lose your job.
Very bad things.
Very much so. Do not document that you did something that parents did. Do not fail to document something that they did either. And don't say that you did it. Well, be honest. Patient's father ventilated patient using bag valve mask during return trip. Patient's father reinserted trach. Flight crew performed sterile trach change in ambulance in accordance with their protocols. Put it in the report. Put it in the report. Because now I have to turn this into insurance, and I'm not sure that I'm not committing an insurance fraud because I know this is a false report. We'll deal with that later. I've got some things I'm working on to make sure that this gets corrected the way it needs to. So,
to be honest, as a provider, I wouldn't let a parent bag the patient because I don't know your competency, and bagging is something that you do need to be pretty competent in. And I've seen very few EMTs that can bag correctly. So I don't know about that one.
Okay, you stay on non-mute. Let's let everybody kind of chime in on that. So I'm a provider, or I'm a parent who's been taught how to care for a trach patient. would you trust me to bag the patient?
I'd go err on the side of caution. I'd agree with her because if the medical director found out, it's kind of the same line. Not saying I'm not going to listen to the parent because they do have more experience dealing with their child than I do, but when it comes to stuff like that, I mean, there's no reason why I can't do it myself or have an EMT do it, or vice versa. And of course, there's special situations for all that, but if I can avoid
Right.
it, I probably wouldn't have them do it.
I'm
Okay.
the opposite way. I'm going to trust the person that's probably done it a lot more than me or the EMT sitting across the seat from me. And be like, you've done this how many times? Okay, you got it till I see you screwing up.
So with that in mind, you've got two different viewpoints.
So can I just add one more thing that I thought of? Yes, you may be extremely competent as, like a special needs parent on any other given day, but your emotions are probably, I mean, like they better be through the roof. Shaky hands, just you're not going to be performing as competently as somebody who's more removed from the situation and doesn't have emotion in the game.
Okay.
As somebody that has performed emergency procedures on somebody that they've known, like, man, I got to be honest, like have had to pause and be like, all right, calm down, this, why are you being like this, so I don't
Now,
know.
okay. Now let's add one more
I
little.
guess
Go ahead.
I guess I kind of chime in. I guess I'd be kind of concerned like liability in a certain sense of like
Yeah,
if
for sure.
something does go wrong, like that mean that's putting your everything you've worked for medic and work and everything else. It could just be like go away if that parent does something wrong,
Yeah,
Okay.
I mean,
even
and
inadvertently.
I'll just say, as someone who's walked into one of these scenarios as a provider, it was my first time, despite having done this for years, that I've had, it was an 18-month-old in
Mhm.
cardiac arrest. By the time we get there, the special needs parents have probably been dealing with this. Like Chris said, they're not going to call us for any little thing. It's going to be when it's finally past the point where they can handle it. That call, there was me. I mean, at some point we had everybody up to the chief of our department there. And I think the parents were the calmest people on that scene, if I had to go back and be honest, because for us, it was, oh my God, it's a child in cardiac arrest. And for the parents, it was, I mean, I hate to say it, but they had seen this coming and basically were surprised it took that long to get there.
Okay. Well, so let's go and ask the two senior medics that are in the room what they think about this. That would be Ms. Dinsmore and Mr. O'Boyle. What do you guys think about this subject? If you had her in the back of an ambulance, do you let the parent work or do you take it from them?
Well, the resource or crew resource management really plays a big part of this, as well as tenure on the job. I need to preface something. I am very impressed with this group and the quality of questions here. I'm a senior educator for Special Operations Combat Medicine, Green Beret Navy SEALs, trauma surgical PAs, and I am absolutely just blown away with some of your guys sharing and some of the questions I got. Outstanding folks, great audience. I see Margot's point. I think it's absolutely great, but the latter is the big thing. And as a clinical advisor for advanced practice paramedics as well as street paramedics, and if the mother is calm, or the caregiver is calm and is working with me, we have a lot more we could be doing. And again, crew resource management. I know the three people that responded to G, you had an AMT, a paramedic, and an EMT. Well, somebody is operating that unit. So that left two in the back. There's a lot of things happening back there. There's got to be continually long assessments, even some neuro assessments, even though his foramen magnum is a little shy. But we've got to be doing this, looking for agrocyanosis, all these things that manifest. I can see everybody's point. My comfort level is again, judging the parents. And if they're in that mode of, hey, you're here to help me, We've been dealing with this for a while. That's it. If they are disassociated, then I'm not going to allow them. But Margot has a right, because if the parent is very well trained, or the parent is just trying to help, I see Margot's point. I'm not going to increase barotrauma, induce ventilatory lung damage. But if it's someone like Chris, that you have had this experience, and your strength really comes through on this presentation, by the way, but it's there, sure, I'm going to let you do it.
Ms. Dinsmore, what do you think?
Well, first off, thank you, Patrick. We do pride ourselves on our students, and this is an especially good group here tonight, and I'm glad you were able to join us. I'm going to agree with you. It's really an assessment of each individual situation. Each time that I have gone in my history, not just over the last few years where it's become even more of an issue with home health care, special needs being taken care of at home, but even further back than that, each situation was different. But what I have seen over the last 10 years or so has been that shift in managed care, where a lot of the patients that normally would have remained in extended care facilities over time are now being shifted and have been shifted to home environments, with the caregivers being family members who are being being provided oversight with home health care, who are coming in however many days a week. But these parents are typically being highly trained now. So managed health care has driven a lot of what we see today, and is a big reason why this has shifted more into a home environment. But to make that happen, it means the training has to be there for the parents and the family. So you have good points, like Margot. I understand what you're saying perfectly, and that's why I say each individual case has to be assessed by you, the lead paramedic, the crew, when they get there. How with it does the parent seem? Do they seem overwhelmed? Do they seem exhausted? Which could impair their ability to function. Or are they, as you said, like Chris, that it's obvious that this parent is clicking along, they're so used to dealing with this, then I'm going to defer a lot of things to them and their abilities, so that, as Patrick was saying, I can also focus on expanding my section of the care. I'm still going to continue to oversee what they're doing, because ultimately in the back of that ambulance, yes, you're correct. The lead medic there is responsible. However, that parent, that caregiver, knows more about that patient than anyone else in the back of that unit. So take each individual situation, assess where they are, where they seem to be mentally, physically, those type of things, make a judgment and move on. But be very careful not to cut your nose off to spite your face in outranking them, so to speak, and overlooking that they are a part of that healthcare team in the back of that unit, and they're trained to be there. So I guess that's where my mind goes in answering your question.
I appreciate everybody's viewpoints on that, and it is going to be a judgment call. Margot, you're exactly right. It's a judgment call based on what you see and what you feel comfortable with. And not every medic is going to feel comfortable in every situation. I still don't feel comfortable in certain situations. I'm not going to say that. But utilize what you have. And guys, thank you for sticking with me. I'm sorry, ladies and gentlemen, I have 3 slides left. I'll get through these. We'll get out of here.
Could I ask a quick question really fast on that last thing? Sorry. I think you had kind of said that you kind of like started bagging your son during the transport. Is there kind of a way?
Go ahead.
Huh?
Go ahead.
Is there a difference in when you kind of have a parent during like the middle of transport, something changing, and having them initiate kind of that during the transport, versus like them just kind of continuing what they were doing before you arrived?
Understand, this was a call that happened. This was a transfer that he was on. There was a point where we went into an emergent situation. The point was, he got in the truck. It looked like he was sleeping, and he had drifted off to sleep. We were having trouble getting his pulse ox to read correctly, but then he started, admittedly, he looked gray. And that's at that point, it was, we've got to get him out of the car seat. We've got to get him out of the car seat. Remember I said there were certain things I wasn't going to talk about? I'm going to say one right now. I was sitting beside him on the bench seat, and that paramedic was in the captain's chair, and that's where she stayed until such time as I said, we've got to get him out of the car seat. We've got to get him out of the car seat. And at that point, he was noted to be cyanotic, cold, and apneic, and his trach was out. So it was an emergent point. It was a chink. And then we went on. And yes, at that point, I said, I have to bag him. I have to bag him. Not necessarily because I was the parent, but more because I recognized the situation. It's a judgment call. So just be careful where you're coming from in that. If it was somebody, like if his routine was he was on a vent, but the vent broke in, he needed to be bagged the entire time, then that's one thing. But this was a situation where it became a point of emergency. And at that point, the priorities changed in what was going on. Does that make sense, Will?
A bit, yeah.
Okay. I can't speak to every situation. I can speak to the one I was in.
Yeah, for sure.
So a couple of 3 more slides. Does anybody know this quote? Because I'll clarify it here in a minute. It's from a very famous movie. You can hear Tom Skerritt saying this to Tom Cruise sitting outside on the beach. Now, I'm not going to sit here and blow sunshine up your ass, Lieutenant. A good pilot is compelled to always evaluate what's happened so he can apply what he's learned. Up there, we got to push it. That's our job. It's your option, Lieutenant. All yours. Replace the word pilot with the word paramedic. No matter what the call is, we have to evaluate what's happened so we can apply what's learned. And we do push the envelope every day in what we do. That is our job. And it's our option on how we take this. I did a whole lot of self-evaluation after everything that's happened with my son. I did a whole lot of shoulda, coulda, woulda, and it doesn't help much other than to make me evaluate what I've had happen and learn how to grow from it. Remember, growth is not accomplished through comfort, it's accomplished through discomfort, and this is a very uncomfortable thing. So this presentation is over, but I have some advice I want to give you. The first thing, keep learning. Pediatrics was not my thing. So I stopped. I had to do it, but I didn't take any pride in it. I've reversed myself on that a lot. I'm taking pride in learning everything I can about every subject I can to make myself a better provider. The first time I experienced special needs pediatrics was my own son in a crisis situation. I had worked prior to November the 5th, 110 code blues. Numbers 111, 112, and 113 were my own son. It's a very sobering thing. I felt like a failure because I did not feel like I had learned enough to take what was going on. Don't try to process everything at once that happens. After we got back to the ER that night from the failed transfer, I sat in the hallway and I cried because I was trying to process everything that was going on and it wasn't going to work. Take time, get help. Practice in pressure-driven scenarios. Don't practice just the easy skills. You do assessments every day. You need to practice the skills that you do once a year, twice a year. And you need to practice them in ways that give you some pressure to perform, because it's in that process that you get muscle memory, that you get instinct built up, and you know how to use it. And then when you get those instincts, you trust them. Trust what you've learned and who you've learned it from, and use their knowledge to make your practice better. So this is you can get in contact with me. Do you have any questions or comments or foul thoughts? And yes, I'll take the foul thoughts too. Here's my contact information. You're welcome to reach out to me if you have further things you'd like to learn about this. If you have improvements to this presentation, I'll get to that in a minute. Please talk, get in touch with me. This isn't something that's easy, but I'm hoping that by doing this, everybody gets some help. And then if anybody wants to take this to their department, I will more than happily, if you give me a person to talk to, I'll more than happily present this presentation. The fire department just up the road actually wants this presentation because this is something you might see once a year, twice a year, but it's going to scare you every time you do if you don't have some thought go into it. I'm more than happy to give this presentation